hormonal evaluation, male and female, is important. And coming to the male reproduction, this is a simple figure I've taken from the internet, and that shows that in case we look at the database, the levels of the hormones, in case we look at them, they are, this is the hormones, when you look at them, they are at the puberty. That's the time when we get the spike of these hormones, and before that the hormones are subdued. And as we age, basically it's about FSH, and as we age they go and hit the upper ceiling. Look at the female responds to the FSH aging with very great rise in FSH, but in the male it is around 12, 13, 10. That's the way the females and males respond. But one thing is for sure, that puberty is gonna spike and then gradually is gonna maintain a plateau and then keep going up and die off. So look at this. When a child is born, in the fetus, there is some amount of FSH coming. FSH comes because it's gonna activate the hormones in the genitals, and then it comes down to very basal levels. Childhood, some peaks are there. FSH more than LH. LH is one rogue hormone. So I always say one rogue in the whole of IVF is LH. It's got 4 friends. LH has got 4 friends, and once you, as we see how we are moving ahead, as we move towards adult reproductive period, all these 4 friends will join in now. 4 दोस्त हैं LH के, friends हैं, which create all the chaos in the life. So let's see how we can eradicate them. So as we are moving ahead, the LH starts becoming more as compared to FSH many times and creating problems. And then the FSH will rising higher, more in the females, less in the males. So as at menopause, we have a woman having a higher amount of FSH, 30, 40, but the male will have around 8 or 9. And it's not that male are not aging. People say male never age, but definitely male are aging. Male have got less amount of FSH, more amount of FSH, less amount of testosterone, lower seminal volume. And after 40, the males are now aging. Things are changing. I probably after 10 years will agree to this. And ASRM has already said that the male DNA is going degeneration. It's got paternal problems after 40 years of age. So male is no longer that invincible Arabian horse. Male is also falling down. So just looking at this small diagram about which you all know, hypothalamus brings GnRH. So not very complicated. Hypothalamus brings GnRH. GnRH will act upon the pituitary gland, and as the pituitary is moving, pituitary will release either FSH and or LH. Like we have 2-cell theory in the females, we have a 2-cell theory in the males also. Male testes has got 2 parts. It's got a part which has got Sertoli cells, and it's got a part which has got Leydig cells. Sperms are add-on. Just remember that sperms are just scattered there, but basically it is Sertoli cells and Leydig cells which are there in the testes. The functionality of the testes is not known by the sperms. That is, it's a functional assessment. But what is happening in the testes is the balance between the Sertoli cells and the Leydig cells. Sertoli cells are being controlled by the FSH, and Leydig cells are being controlled by LH. Sertoli cells, what do? Sertoli cells is like a feeding mother. It's a breastfeeding mother. So for a newborn baby, whatever you do, your baby may be 4 kgs, 5 kgs, whatever, in whichever country, in case mother won't feed, the baby won't do well. So sperms are akin to a newborn baby, and the mother is a breastfeeding mother, and this is the FSH. So I'll always this is Sertoli cell. I'll always say mother is Sertoli cell, and sperms are newborn babies which are lying there. Large number of them are lying there. So in case Sertoli cells are not nurtured, in case now mother is weak, mother is anemic, sperms will be weaker. So focus is always on Sertoli cells in the body. So FSH acts here. And then on the other hand, Leydig cells will secrete testosterone, which will go and act upon the Sertoli cells and the maturing sperms so that they undergo complete spermatogenesis. So what I want to tell you here is that besides all those negative and positive feedbacks, forget them, don't talk about them. Just know that there is a LH compartment and FSH compartment. FSH compartment works upon Sertoli cells, and LH compartment works upon, is being acted upon by the, LH is acting upon the Leydig cells and making testosterone. So this is the way things are moving, and I'll try to make it more simple as I move ahead because this is a very important topic. So we have anterior pituitary here, and we have FSH and LH here. LH is on the Leydig cells, and Leydig cells, they make testosterone, and Sertoli cells, FSH acts upon the Sertoli cells, and what do they make? Nothing. What does a mother do when a mother breastfeeds the child? It doesn't do anything. It keeps breastfeeding, and finally child probably will leave the mother and go. Child will go to Canada or USA, leave the mother behind. So sperms, they keep moving out. The mother is always feeding. So one Sertoli cell will feed probably millions of sperms, and sperms will keep going out to the greener pastures. But Sertoli cell will be there only. Actually does nothing. It's just sitting there like a brick and helping the sperms move, but playing a very important role. And they nurture these sperms, and this is what they're feeding these sperms, as you can see here. Okay, now another small diagram. You can see that this cutout of a testicular section. We have inside the testes, inside the seminiferous tubule, we have sperms and Sertoli cells. So you can see here, this is the lining of this. We have Sertoli cells, and then we have got sperms at various stages of development. Leydig cells are outside the compartment. This you have to know. Leydig cells are not part of seminiferous tubules. They are just lying part, but they're lying outside. They are the Leydig cells. And Leydig cells are acted upon by LH, and Sertoli cells, which are lying here, are being acted upon by FSH. And few sperms are lying here. Sperms are just coming and going, but Sertoli cells is like Taj Mahal. They are there. People come and watch, go, but Taj Mahal will be there. And LH is something, and Leydig cells are, I'll just talk about Leydig cells as they move ahead. So I want you to get some basic concepts about Leydig cells, Sertoli cells, because people normally go there wrong, probably not go wrong there. They don't know that they have to look at these facts. So look at this thing. Sertoli cells are lying in the seminiferous tubule, and there are sperm precursors in different colors. There's a basement membrane, the blue basement membrane, and all these sperms are being made and going out. And these guys are, pink ones are the, red ones are the Sertoli cells. They're lying there like a Taj Mahal. People come, visit, and keep going off. And they, as they mature, they go in the canal and they are either lost or they make babies. Leydig cells are lying outside. This I wanted to, first message, मैंने आपको ये देना है. Leydig cells are outside the seminiferous tubules. Once you've understood this, our job will become easier. Now, to make you understand, I would like any one of you to speak. Don't think much. Just speak. More you will speak, more you will learn. I'm showing you a picture of a lovely buffet to which I invite you today. You've invited for nice Independence Day buffet. Somebody invites, so let Garima invite us today. She is launched into the nest. So big nice buffet is there, and time is 9 o'clock in the night, and we eat to our heart full. We've enjoyed the food, lovely food, lovely food. Thank you, Garima. Lovely food. Now, can she serve the same food tomorrow night? Khana bach jata hai na? This much food will be left also in the buffet. So can she serve the same food tomorrow or day after tomorrow? Anyone can talk.
No.
Why can't she?
It can be stored. It can be spoiled.
No, keep in the refrigerator, keep in the fridge.
Be stored.
Yeah, then you can serve it tomorrow.
Change the
But it will change the taste.
I know.
Sir, but that is, it depends upon how we store, but we can utilize it also, or we can give it to anyone who is in need also.
Correct. But we can't store much. 1 or 2 days maximum we can do it, right? We can store it. What happens after we have had the food? People call me crazy. They say your examples are stupid, but in the end they realize they were meaningful. So I'm gonna take you to a concept. I'm not wasting your time. So let Usha Menon enter. She's waiting. Okay. So now coming to after we have had this food, what will Garima offer to us? खाना खा लिया अब क्या देगी खिलाएगी before she sends us home?
Dessert.
Dessert खा लिया. Dessert के बाद में क्या देगी जाते हुए?
mouth freshener.
Mouth freshener.
Thank you.
Good. Our favorite imli ki goli is served everywhere. I always remember the olden days of airlines when Jet Airways used to give us imli ki goli. It may be still giving with a sandwich. Imli goli you normally get. Okay, then some people give candies. So vis-a-vis the food, lovely food which she served us, which we can't store for 1 day maximum. How about these candies and these imli golis?
This can be stored.
How long can they be stored? Candies, how long?
About 6 months.
6 months,
Oh,
1
as
year,
it does not expire.
maybe 4 months, 5 months, maybe. Agreed. Maybe, but it can be stored. Definitely, yes. Fresh food can't be stored, but the imli golis can be. You can put on your mics once. No. I think a lot of noise coming behind. Please help me and mute yourself. So the causes of failure in the male can be pre-tested. Then we have testicular and post-testicular. 3 causes of male infertility are there. Pre-testicular means that there is nothing coming from the top. Hormones are not coming up on the testes. Testes is normal, but hormones are not coming. So it is called hypo. So please, very simple things I'm telling you. It's called hypo, where it will be hypogonotropic hypogonadism. It's pre-testicular from testes. So whatever may be happening, but the levels of FSH and LH are low here because the hormones have to come from the anterior pituitary. When this compartment is going bad, then there is no FSH LH or less in amount or maybe absent completely. So FSH LH is low. When it is low, it can't work. It cannot work on Sertoli cells and Leydig cells. Obvious, it cannot work. So LH FSH low means testis is fine. It's going to work, but there is no hormone to stimulate it. Great. This is about LH FSH theory. So we have hypo. In case you give these people hormones, testes will start working. Second is testicular, where testes are not working. When testes are not working, what happens here? I'm taking you through those lovely food. I know you all must be hungry. So when we go through this, we'll find that here this compartment is locked off. This is not working now. There are no Sertoli cells, no Leydig cells. This compartment is gone. And when this compartment goes off, what happens? We come to an answer that we have increased FSH and increased LH. And post-testicular means there's a blockage. So here testes are working okay, brain is fine, but our plumbing is bad. Here we have plumbing issues. Here we have the plumbing issues. Here LH FSH is normal. So why am I telling you these things? It's about the interpretation of the reports. So in case you have this compartment, there are 2 compartments in the male. One compartment is this, that is called one compartment, second compartment. Compartment number 1 is FSH, 2 is LH. FSH works upon the Sertoli cells and LH works upon the Leydig cells, and then Leydig cells will secrete testosterone. Sertoli cells, they do nothing. They are like feeding mothers, babies come and go. So this compartment is very sensitive. And this is very hard. This is like a buffet. Expiry period, 8 hours maximum. By morning, food goes bad. LH compartment is like a candy. Nothing happens to it. So what I want to tell you is that when any problem to the testes, Sertoli cells, they knock off. And when they knock off, then levels of FSH will increase. Testicular volume will become small, but LH will remain normal. So LH will remain normal because Leydig cells have no issues. They are working. And testosterone is normal. So you'll find a large number of men who come to you, they have small testes. This is very important concept. Please be with me. Small testes, increased FSH. But when you examine them, their LH is normal, testosterone is normal. That's the beauty of it. LH is a very hardy cell. It's like a candy. It doesn't expire. You just keep it in the refrigerator and you can eat it after even 1 year. So LH can survive the trauma injury for a long time, and FSH is like something like a Kolkata sandesh. 6 hours, it goes bad. Just keep it in the mind. You people get confused that why LH is normal, testosterone is normal, but he's got going into testicular failure. So that's the reason I wanted to tell to you. So when we have primary testicular failure, we'll always find that we have elevated FSH LH. So they write plus minus. I think I've given you the answer today. You would have learned why is it plus minus, because Leydig cells can escape. So LH is working properly, but Sertoli cells, they fail and FSH goes high. LH is plus minus, but eventually even LH will go. And they have normal or low testosterone. So FSH will remain, FSH will go high, Sertoli cells will shrink, food will go bad, buffet will be thrown off, no sperms. But the Leydig cells are working. LH is normal, testosterone is normal, and his virility is normal. He's got no problem. This one beauty of the male compartment. It doesn't happen in the female that way. When we have low FSH, LH and low testosterone, what condition will that be? Anybody?
Hypogonadotropic hypo.
Beautiful, beautiful. And when it is normal?
Pituitary failure.
Wow, great. And when it is normal?
So the testes are normal, but the plumbing effect is
Good, good. You speak my language. Great. Coming to female reproduction. These topics are very complex. Correct, post-testicular, very right. These topics are very complex. We take around 6 hours in our batches to cover this. What I've told you in around 15 minutes, we take 6 hours for this concept in our classes. But I'm happy that you've understood the word plumbing. Thank you so much. Female reproduction. Our number has touched 243. So I think we have won. Our family has won. You took the pledge with me that we'll keep learning. So learning on the Independence Day also. They gave me a challenge. It can't happen on Independence Day. But thank you so much for joining in. Okay. Coming to female reproduction, we have a menstrual cycle, we have LH and P4. 3 concepts है आपको समझने सिर्फ 3 concepts, and I'll give you the right answers within the right time without any conflict. They are the final word thereafter. Menstrual cycle is a pretty complex phenomenon. A lot of hormones come. It's something boiling inside. We don't know. Actually, we still don't know what all is cooking in the woman's body. But it's a very, very acute phase of her month when she's boiling inside. And these are the various phases of a menstrual cycle as we look at it. When we have a follicular phase, we have ovulation phase, we have luteal phase. In the ovulatory phase, these small little babies, small little cells, oocytes are maturing. They are maturing, and they start maturing because the levels of E2 are less. When the E2 is low, then the FSH comes. When E2 is low, we find E2 is empty. Can you all see this? Can you see what I'm showing to you? Yes or no?
Yes, sir.
Yes, sir.
Yes, sir.
E2 is low. Your car shows no petrol. Car shows no petrol. Empty petrol. FSH comes through. It's not empty. It's around 25 picograms. FSH pops in from pituitary. When E2 is low, FSH comes. Follicular phase starts. Under FSH, these will mature. And as they're maturing, E2 will go high. So E2 from 25, that become 250. When E2 goes high, E2 has got a friend, and that friend is LH. E2 calls his friend LH, and LH comes and just spanks the follicle. And when it spanks, the egg comes out. So here comes the rogue. You see how they have shown LH? LH is a rogue. We don't know what it keeps doing in the body all half the time. And we are trying to find out about LH. We still don't know. Great. So when LH comes and spanks, LH is always spanking. It comes in spikes and spanks and goes back. It's like a mercenary. It's like a pirate, you know. It's like a pirate. Pirate comes in the midnight for half an hour, robs a fish, robs the ship and goes off. That's a pirate. This is what this thing does, comes and goes back. So we have a corpus luteum. Then after the egg is out, we get corpus luteum formed, and that will secrete progesterone, and progesterone will be in control for next 14 days. So part 1 is follicular phase estrogen, and part 2 is progesterone. And then in case there's no pregnancy, progesterone wears off, and then there are periods again. So what we have to remember is that E2 is around 250 picograms per ml on average in the follicular phase, and the second part is being headed by E2, by P4, and P4 varies between somewhere around more than 10, definitely 10 to 25 nanograms per ml. So E2 values are pretty high as compared to P4 values. Until you won't understand this concept, we cannot understand the role of hormones.
P4 क्या प्रोजेस्टेरोन हो गया?
So now
E2 estrogen है ना?
So the initial part, we look at the ovulation. Ovulation is occurring here. The initial 14 days is for E2, and the second part is by P4. Just remember this. Both of them are here, but initial 14 days are for E2, and next 14 days are for P4. You'll find that initially the E2 levels are low, less red, and then it keeps going up. Starts with around 25 and touches 250. And then it brings LH, and LH is gonna rupture the follicle, and then ovulation occurs, egg comes out, and then forms a corpus luteum, and then E2 will fall down and just maintaining a small peak. But P4, which was actually very low, P4 is normally around less than 1. It is less than 1 nanograms per ml. Here, P4 is less than 1 nanogram per ml. P4 is going to rise to the values of around more than 10, I would say that, more than 10 nanograms per ml. This is about the E2 and P4, how it happens in the body. It's again, we take around 8 hours. This topic is worth 8 hours for our IVF patches, but I'm just summarizing the information to you in very simple words. Here we again find that the pink is E2. The pink is E2. E2 starts in a very simple way here, and E2 keeps building up, then E2 comes down, and progesterone which was around less than 1, goes up to around 10. Green is the progesterone. And in the initial phase of the cycle, we always have FSH. FSH, when we start any cycle, is blue. FSH is blue. It's got very low values. It barely is around 4 to 5 MIUs per ml is the FSH. And FSH, we have a small peak here. This is a window, FSH window we call it, where FSH slightly goes high, stimulates the egg, and then veers off. And when it veers off, then comes the follicle starts maturing, and then we'll have again a small peak of FSH at the time of ovulation. So FSH, understand that FSH has got 2 peaks, and E2 has got 2 peaks. Just remember this. That's very important for us to know. One thing being missed everywhere is that even progesterone will have 2 peaks. This is not shown everywhere. So even progesterone will have 2 peaks. One peak is here, big peak, and one small peak is here. And this is the peak which actually is the danger for all of us. It causes all the problem for everything. This peak here. We'll talk about it. So again, a small picture, we can find that we initially have FSH, which is green. FSH, 1 peak FSH we get here, 1 peak of FSH, second peak of FSH here. Then we look at the peak of estrogen, starts with 25, touches 250, then goes down, and the second peak of E2 here coming here. Then we have another peak of, now then we have 2 peaks of progesterone, and here you can see progesterone starts building from here and then shows the final peak. So progesterone has got 2 peaks, and this peak is the killing peak. And this killing peak is the one which comes along with the LH. When LH peaks, progesterone peaks, and this peak occurs before ovulation. It doesn't happen later. It peaks before only, and this is what we have to keep it in our mind. And this is the most important part which we have to understand. So we'll come to this as I come to the main slide. So we find that the hormonal profile, initially we always have estrogen, and then in the second part we have got progesterone. And this is one thing you have to keep in your mind all the time. And I'm coming to the very important slide for all of you. When we look at this slide, we'll find that when we look at the onset of LH surge, LH surge is the one, in case you say what to avoid in the IVF. One step in IVF in which we can avoid and we have a better pregnancy outcome, that will be LH peak. In case we can avoid LH surges, then IVF is all done. So all our agonist and antagonist protocols are trying to avoid this LH surges. A natural LH surge, if you look at it, that is for 36 hours. I've written here. So LH surge occurs for approximately 36 hours. As you can see here, it's got 2 parts. Initial part, as you can see here, this is before ovulation. LH surge will occur before ovulation, and then we have ovulation. So we have a surge, we have one part, ascending peak of around 24 hours. Then we got a peak, and then the second part is 12 hours. So in this part, on average, when we have this peak occurring, after this, we get ovulation. So ovulation, होने से 36 घंटे पहले LH onset starts. What I want to tell you here is, just try to read what is written here. It is written here that LH surge to ovulation is 36 hours. I request people to unmute themselves in case possible. LH peak to ovulation will be 12 hours. And LH surge onset to LH peak is 24 hours. This is a simple concept, difficult to understand, and it takes hours for us. It takes hours to understand this part, but here what I wanted to tell you is that as far as possible, try to understand this, because this will help us. This will help us understand the whole concept. So coming to the part 2, in case we have any problem with the LH peak here, we have any problem with the ovulation, then we'll have defective luteal phase defect. So all the peaks have to be fine, T2 has to be fine, LH has to be fine, ovulation has to be fine, everything timed well. So I request people to unmute themselves. There's a lot of disturbance coming. So when the E2 has got 2 peaks, P4 has got 2 peaks, and FSH has got 2 peaks. When they occur properly, all the peaks occur properly, then we have good luteal phase. So LH trigger endocrinology. In very short, I will tell you about what happens with the LH peak. What you find is that, let's look at LH trigger endocrinology. As I've told you that LH, this is the time when we're having our ovulation. This part will be 36 hours. So 36 hours before, LH will start rising. That's important for ovulation to occur. Before 36 hours before ovulation, LH will start rising high. This you have to understand. And as LH has peaked, then after 12 hours, or after we reach here, after 12 hours, ovulation will occur. So this is how it happens. Onset of LH surge to ovulation, 36 hours. Normally, I like to go into the ascending curve, plateau, descending curve, talk about their schedulings. But here, I just want to leave a message to you that you must know that it happens that way. So total, there are 3 limbs of this. One is ascending, plateau, and descending. So this limb is always 14 hours, plateau is 14 hours, and this limb is 20 hours. So total time LH can act in the body, the natural LH can act in the body is 48 hours. This you have to remember. So I should try to show you some nice pictures, but LH we have to have a ceiling. LH is a rogue hormone, I've told you, but we have to have a ceiling. In case LH should be between 1.2 and less than 5. So 1.2 to 5 is the LH. If LH is less than this or more than this, there's a problem. So low levels, high levels can cause problem, and ideal is optimal levels. For everything, when everything goes well, we need between 1.2 and 5. And when LH is less than 1.2, it will occur in hypo. Same like the man, hypo. And when LH is very high, this can occur in poor responders and in aged women. This you also have to know. PCOs will have a high levels of thing. And how do you apply it to our practice? So this is what will interest you. Whatever I build around till now, I've created a building so that you can come and live in it. This building doesn't have any furniture or doesn't have a TV or a kitchen. You won't enjoy living there. So when you want to live, just know that LH trigger with HCG or with agonist will only act when the basal levels, primarily with the agonist trigger, it will only act when the basal levels are more than 1.2. Less than that, your agonist trigger may not work only. We give a lot of women agonist trigger in IVF. It doesn't culminate. We get an empty follicle syndrome, and that occurs when the LH values are less than 15. Whenever you give a DECA trigger or Lupride trigger, 12 घंटे के बाद में look at the LH values. In case they're less than 15, the trigger has not worked. It's one take-home message I want to give to you. Just a take-home message. Second, in case woman has got basal LH of 1.2, don't give agonist trigger, it won't work. Always remember that LH surge is 10 to 20 times of basal value. When we start, LH basal values are 1.2 to 5. So when you start the cycle of LH, it's like this. But when LH peaks, the peak can be maybe 5 into 20. So it may touch 100. From 5, LH may go from 5 to 100. Just remember, this is a huge number. The way LH goes up, no other hormone in the body have so much of jump. No hormone in the body has a 20 times jump during this small period. All are 8 to 10 times, but 200 times in one go to have a surge is very rare in the body. So basal values are this, and it may touch 100 to 10 to 20 times the basal value. And this is the basic idea of telling you these things. Now, when we are giving somebody, looking at the LH natural curve, look at the LH natural curve. So LH natural curve will be, its total is 48 hours in the body. Out of 48 hours, it disappears. When you give somebody HCG, that will act for around 1 week. And when we give somebody agonist, the peak will be only for, the whole thing will be only for 24 hours. So lesser is the peak of LH, safer we are, because less chance of OHSS would be there. So we need to have a lesser peak. Just remember that. So we are nowadays shifting to trigger with agonist. This small thing you have to understand. This figure, I'll give you 1 minute to just go through it. Just see this picture and look at the HCG when we give from outside. Look at the natural LH surge in the woman as it occurs, and then look at the GnRH peak. I'll give you 1 minute to read this slide. It's very important. Assimilate, and then I move it. So as I told you, HCG means 1 week. Agonist means around 20 hours, approximately 24 hours. A natural peak means 48 hours. It's a crazy concept to understand, but I want to drill in your mind how it happens. GnRH 24 hours and natural 48 hours. GnRH has got no plateau. They got a no plateau here. This you have to know. And natural has got a plateau of 14 hours. So as you can see here, when you give somebody an LH, it will touch, the levels may go high, but it's got very short, and then it will fall down very quickly. In 48 hours, it will fall down. But when you give somebody HCG, it's going to go very high. The levels of LH may go very high to around 140, 200, and then it will sustain itself for around 1 week. And this all will lead to OHSS. So as far as possible, we want to focus on a short trigger with LH nowadays.
Why not?
With a strong endocrinology. This is very important. P4 is always very confusing. It's always very confusing. So I'll talk about P4.